Recording. There we go. So now we're recording again. Okay, everybody hears me now?
Yes.
Okay, good. Good. I was just rattling away and nobody could hear me. Hopefully this will be short and sweet. We're only covering two things today. We are covering the surgical intervention. So basically heart catheterization and coronary artery bypass graft, which is another name for open heart surgery. So hopefully we can just zip through this. Of course, every time I say, well, yeah, it'll be quick, we end up on here an hour and a half, don't we? But anyway, let's dive right in. There we go. Keep an eye out for this guy. As you all well know, and pass it on to the other students, I don't give out a study guide. I don't like study guides. Study guides are either usually too specific or they're not specific enough. I highlight in my PowerPoint slides those things that you need to study for the test. So keep that in mind. The objectives for the day, we're going to look at the concept again, because we always have to do that. And then we'll talk about cath lab and CABG. Does this look familiar? Perfusion refers to the passage of oxygenated capillary blood through the body's tissues. My guess is you'll probably see that again. We'll start with the first one. Now in your ATI books, they are listed as percutaneous coronary interventions. Basically means we stick a catheter in you. Now, when I was in the hospital, we always went in the femoral artery, and I'll have a diagram up here in a minute that'll show you that's in your groin area. And that's how we've always done catheterizations. I have understood from other people I've spoken to that they've actually gotten specific enough now, they can actually start going into your brachial artery to do catheterizations. I hope that's true because you'd spend a lot less time in bed if that was the case, and you'll see why here in a minute. Normally what happens is the individual goes into a catheterization lab, and it's done under fluoroscopy. And fluoroscopy is like a constant x-ray, because what they do is they run a catheter into your heart and they shoot dye, and that dye lights up your vessels and they can see where the blockage is. So in order to see that, they have to have a constant x-ray going so they can see your heart. This is the most common procedure for myocardial infarction or a heart attack. In other words, you get a plugged artery in the heart. Now you could use a cath lab for other things as well. I think ablations for things like AFib, I think they have their own lab for that. I don't think they use the cath lab. But there might be other circumstances where they have to go in and do something with the heart. There's three different versions of percutaneous coronary interventions. Basically, there's the roto-rooter, and that's where they run that catheter into that vein that's plugged, and they just cut out the plaque. Now, as you can imagine, there could be some really bad side effects to that. You're cutting up the vessel. You're also cutting plaque loose, which can travel through the body. I don't see this a whole lot, but it's out there. The second one, which is far more common, is percutaneous transluminal coronary angioplasty. That's a mouthful. Say that fast 3 times while eating crackers. Balloon angio is what we call it. It's a balloon angioplasty. Basically, what we do is we just take and put a catheter into the vessel that's plugged. We inflate the balloon, and it pushes all the plaque up against the wall, and it opens the vessel back up again so that your heart can breathe. Now, the last one here is a stent. Now, we have to do the balloon angioplasty as a part of the stent. Let me see where the diagram is. Yeah, here we go. This is a good way, better way to look at it. Now, here's the balloon angioplasty. We basically move the balloon into area that's plugged, and we inflate it, and it pushes all the plaque up against the vessel walls. With a stent, we have this little wire mesh, and it goes over the top of the balloon. Then when we inflate the balloon, it pushes that mesh up against the wall of the vessel, and the mesh stays there, and we pull the balloon back out again. What this stent looks like, if you ever take apart your Bic pin, I don't have one with me. You take apart your Bic pin, and that little spring in your Bic pin, that's exactly what the stents look like. I don't think Bic makes the stents though. So that is the third type of device, or third type of catheterization that we do on the heart. Now, when would somebody want this done? Usually, if a person has been having a lot of heart trouble, a lot of angina, and the doctor, the cardiologist decides, okay, it's time for us to go in and actually take a look at your heart and see what's going on and maybe open up some of those occlusions. The other time when it may be indicated is when a person actually just comes into the ER with chest pain, or if they go down at home and the family's doing CPR and the paramedics rush out there and they defibrillate them and they've got a good heart rhythm back, they rush them into the ER. We always just go straight to the cath lab. When I was in the ER, when they called up and they said we have, person who went down from chest pain, and they had to defibrillate them, we just call the cath lab and say, get ready, they're coming. And they could just go right through the ER and go straight into the cath lab. It's the quickest, most efficient way to fix the problem. And they're very common now. Almost every hospital has a cath lab now. The way we find out, and I don't know if I have a picture of this. Let me see if I do. No, I don't see it. I was trying to find a picture, but oh no, I put a video in there. If you guys watch the video shows how the heart is beating, and they put the catheter into the heart and they shoot the dye, and you just see the vessels, you see the dye comes through in black, and you see the vessels all light up on the heart. It's really cool if you ever have a chance to go to a cath lab and watch it. And the vein is occluded, you'll just see a big black line come across, and then suddenly it'll just stop. Let me show you here. So you'll have a big blood vessel going along like this, and when they shoot the dye in, this is all black in here, and then all of a sudden, boink, it just turns to a tiny little trickle. And they know that this is where the occlusion is in the vessel. So once they identify what vessel's occluded, and they identify the percentage of the occlusion, they can go in and either put a balloon in there and do a balloon angioplasty or put a stent in that vein. But if it's an extensive occlusion like this, or if there's 4 or 5 vessels that are occluded, they might not do a catheterization. They might just stop and say, okay, transfer them over to the OR. We're going to do an open heart surgery on them. I probably told you the story of my good buddy who went to the cardiologist, and the cardiologist said, you got the heart of a 20-year-old. And then he got chest pain and was flown to Phoenix, and they went into the cath lab. He had 5 vessels occluded. So they didn't even bother doing a catheterization on him. They just moved him right over to the OR, and they did a CABG, open heart surgery on him, which is what we'll talk about next. So that's what's cool. But the thing to remember about this is we are using a dye. We're shooting a dye in that catheter to light up that heart, and so we could see where the vessels are. And there's certain considerations that you as a nurse have to take into account when we're using dye in a patient. And I'll talk more about that here in a minute. Once the occlusion is identified, then they either do the balloon angio on it or the stent. And like I said down here, if it's too much for a catheterization, they just swing them out over into the OR and they go straight for a CABG. Any questions on that so far? I'm sure out there in the audience, probably at least half of you know somebody who's gone to the cath lab. It's a very common procedure now. And it saves lives, tons of lives every day. So how do we know if a patient's going to go? Let's say we don't have the ambulance screaming in with people yelling, I got cardiac arrest. Someone just walks in and goes, my chest doesn't feel good. And so this is what we're going to look for. First thing we're going to do is we're going to lay them down on a table. We're going to do an EKG. And remember the parts of the rhythm strip. You have the PR interval, which is when the atrium contracts up to when the ventricle contracts. Then you have the QRS complex, which shows the ventricle. And then you have the repolarization period, which is the ST, with a little pause and then a little bump after the QRS wave. What you will see in a normal QRS wave, you'll see this, and then you'll see like a bump like that. And that's in a normal heart rhythm. In somebody having cardiac issues, like a vessel occlusion or myocardial infarction, you'll see this on the ST wave. And that's what we call ST elevation. Now, they may come along and it may be like this, and then the worse it gets, the more it elevates. But when we're doing the 12 lead EKG, there's 12 different EKGs out there. We can look at the different leads and see which lead has the ST elevation. And then that tells us which vessel in the heart that that is occluded. So that's what when we talk about ST elevation, that's what we're talking about right there. And hopefully if we can, on the skills lab during your fourth quarter, we'll be working with the EKG machine and we can show you more about that. Well, at the same time, we're going to draw blood, because every time someone comes in the ER, we always draw blood on everybody. We're going to look at the cardiac enzymes. Now, we talked about these in a previous lecture: CK, CKMB, and troponin. Important one is troponin. If they've got ST elevation and they have a positive troponin, they're going to the cath lab. It's just automatic. We just send them right there. On the subjective level, chest pain, males, elephant sitting on my chest, radiating to the left arm, up into the left jaw. Female, maybe she has chest pain here. It's radiating. It might go to the right arm. She may have pain in her belly. She may have lower back pain. Women present differently than men do when it comes to cardiac arrest. Other things that go along with that is dyspnea, difficulty breathing, nausea, fatigue, especially I was talking about, the different leads, what different areas of the heart. If somebody has a blockage in the lower part of the heart, it can affect the stomach organs, and so they'll get a lot of nausea. I'm trying to remember what part, I can't remember, it just escaped me all of a sudden. And fatigue, because the heart's not pumping properly. They're not getting as much blood as they should. And also feelings of doom. Don't discount this. Sometimes, and not just when it comes to the heart, but other things, but sometimes patients will just look at you and go, I just feel like something's wrong. And we may think, oh, well, it's all in your head, you're okay, you're fine, your labs were good. Don't discount that feeling. When something's going wrong in the body, it lets the brain know something's wrong. So don't ever dismiss that when the patient's saying, I just feel like something is wrong. I would always encourage you to investigate further. I want to remember that. So, any questions on that so far? Nope. All right, dive right in. Before someone goes to the cath lab, You're going to be standing there. The doctor's going to say, get them ready for the cath lab. And you're going to be going, okay, what do I do? Here's some of the things you might want to do. You have to get all the consent forms signed by the patient if possible. If not, if the patient's unconscious, the family member or the power of attorney can sign the forms. Educate the patient and the family about what's going to happen. You want to explain to the patient, you're not going to be knocked out completely, but they're going to sedate you and give you some medicine for pain. And they're going to put a catheter, just like the catheter that goes in your arm, only it's a little bigger. They're going to put it in your thigh, in your femoral artery. They're going to go up into your heart. They're going to find out what vessel's plugged. They're going to open it up. And most patients instantly feel relief when they do that. I mean, you have a heart vessel in there that's, 80, 90% occluded. The heart's not getting the oxygen it needs. And then they balloon it and the vessel opens back up to 80% open or only 10% occluded. And they immediately get flow into that area and people will immediately feel relief from the procedure. It's kind of cool. Other things you're going to need for the patient: height, weight, vital signs. Now, when we were talking about contrast dye, now this not only applies to the cath lab, but it applies to any radiological procedure that involves contrast. Contrast that we use is an iodine-based contrast. So if they're allergic to iodine, of course, we can have some really bad effects, ranging anywhere from just a mild rash all the way up to total anaphylaxis. So you haven't had anaphylaxis yet, but that's when like the person gets stung by a bee and like their throat starts closing. That's an anaphylactic reaction. So it's very important that you know if they're allergic to iodine. Now, one good indication is if they go out to Red Lobster and they have the lobster or the shrimp or crab dinner, and their throat felt puffy or they developed a rash or anything like that. That's a good indication they have an iodine allergy because there are small amounts of iodine in shellfish. So that's why we always ask them, are you allergic to iodine or have you ever had any bad reactions to shellfish? Shrimp, crab, lobster, oysters, clams, any of those guys. Kidney function is also a consideration. Now, when that dye gets in your system, you have to get rid of it. And if their kidney function is not what it should be, it's very difficult for the body to get rid of the dye. So if you have somebody who is in renal failure, it's usually a type 2 diabetic, or if they're on kidney dialysis, then that's definitely out of the question. I don't know if they ever do dialysis on a patient post-surgery or not, but I would think not, because dialysis is really hard on the body. So I think they just avoid dye completely when it comes to a renal failure patient. And you also want to find out about the patient's medications. If this patient is on warfarin, then they bleed easy. And we're going to go in and we're going to poke around in their heart and we're going to be pushing things around in their heart. We poke something and they start bleeding, they're going to bleed profusely. And that can be really bad. So we have to take that into consideration if they're on warfarin or Eliquis or any of the anticoagulant medications. Also beta blockers. Beta blockers have a tendency to slow the heart down. Well, the anesthesiologist wants to control the person's heart rate, not the medications. So usually if a person is coming in for a voluntary catheterization, we will have them off of the warfarin or anticoagulants and have them off the beta blockers for at least a day before they go in. I think warfarin, they usually try to get them 3 days before, but beta blockers, it's usually the day of. They say, don't take your beta blockers. But pre-procedure education, I kind of talked on this already. They'll be awake, given a sedative, an incision, a catheter is put into the groin area. It's important for the patient to remember to keep that leg straight. It's usually the right leg. I think it has to be the right leg because I think they're going into the inferior vena cava, into the heart. So they have to keep that leg. They can't be moving that around, because when you move the leg, you're going to blow the clot that was forming in the artery, and you're going to start bleeding profusely. So they have to keep that leg straight for about 4 to 6 hours after the procedure's done. Any questions for pre-procedure? You got the patient, you've done your consents, everything's all set up, you're sending them off to the cath lab, you wave, bye, see you later. Or you might be in the other side where he just came out of the cath lab, and now you have to take care of the patient after the catheterization. This is kind of, this first one here is kind of true for all post-surgical patients. And the reason for that is anesthesia. We keep a very close eye on their vital signs every 15 minutes times 4 for the first hour, then every half hour times 2, and then every hour. And that's just to make sure they don't become over sedated from the anesthesia and stop breathing, or make sure their blood pressure doesn't drop too much, or any of the other complications that can occur in a post-surgical patient. With the catheterization patient, very important to keep an eye on that groin site. That is your main area of focus after someone comes out of a cath lab. You need to inspect the site, keep an eye on it, make sure the dressing's intact, there's no bleeding, and there will be pressure on there. We used to use sandbags. We used to put sandbags on the area to apply pressure. Then they have these big clamp type devices that go on there. I think they've got something better now, but I'll tell you, it's been a long time since I did post-cath patients. But I think they have a strap that goes on the leg that puts pressure on the site. It's far more efficient than the sandbags are. But you still have to keep a close eye on it. That pressure will be on the site for usually, I think, an hour or 2 after the procedure. And then we would slowly let the pressure off of the device, a little bit at a time, a little bit off, and then a half an hour later, a little bit off, half hour later, a little bit more, until the device finally comes off. You don't just take the device off all of a sudden. Now you're affecting a major artery in the leg. So you're going to keep a close eye on the perfusion of that leg. In other words, if it's in the right groin, you're going to keep a close eye on that right foot. You want to make sure you have pulses, you want to make sure the foot's warm, you got positive CMS, circulation, motion, sensation, and the temperature. Make sure it's not cool. When the foot starts getting cold, you have compromised circulation. Now, part of it may be, the clamp is too tight on the leg and you're cutting off the artery completely, which would cause your pedal pulses to be weak and the foot to be cold. So you just kind of have to play with it a little to make sure the foot is getting circulation, but you have enough pressure to make sure that the incision for the catheter clots and seals off so that it doesn't bleed. There again, keep the leg straight. The doctor will prescribe how long. Usually it's somewhere between 4 to 6 hours. And that's just because if you start moving around, you could bust the clot out of the catheterization site and you start bleeding again. Monitor urine output. This person had dye in their system. We want to make sure they're getting rid of the dye. They may have a catheter in. I can't remember if indwelling catheter was common procedure with cath patients or not. But anyway, you have to keep a close eye on the urine. And of course, give them whatever medications they need to be given, especially in the form of pain medications. So that are some things that, some of these are specific to catheterization. Some of these are just general post-anesthesia things. For any of you who want to work in PACU. After the patient has gone through the procedure, you're getting ready to get their paperwork together. I think for the most part, people can come in, get a catheterization, and go home the same day. I don't think they necessarily have to stay overnight anymore, depending on the circumstances and depending on the patient. They want to avoid strenuous exercise. They are probably, we'll probably tell them something in the area of Don't lift anything over 5 pounds for 2 weeks. Don't do any strenuous exercise, don't lift weights, don't run, etc. Because they don't, first of all, the heart is recovering from a trauma and you need time to rest and get back up to strength again. And you don't want to blow out that catheter site in the right femoral artery. Educate the patient if there's any bleeding from the site, especially a lot of bleeding, if there's any chest pain, shortness of breath, anything like that, they need to call the doctor, or if they can't get a hold of the doctor, go straight to the ER. If a stent was placed, they may be placed on anticoagulant therapy, warfarin or Coumadin. If they are on warfarin or Coumadin, that requires frequent testing. Anticoagulant medication, warfarin, requires that you get an INR test. I think it's once or twice a week, depending on the circumstances. So they will have to go into a lab. It's now on a portable machine, much like a finger stick glucose machine. So they don't have to like go in, get the blood drawn at LabCorp and wait a couple of days for the lab test to come back. They can usually just go to a clinic, they poke their finger and they get the result immediately. With warfarin, the therapeutic level for INR needs to be from 2 to 3. Did we talk about that in a previous lecture? I think we did. I think we talked about warfarin. I think it was one of the drugs we were focusing on. But as you know, most people, our INR is like 0.1 to 1. A patient on warfarin, we want them to be between 2 and 3. So you'll have to explain that to the patient. Now, if they're put on Eliquis is a little different. They don't need to have the frequent testing, but they still need to be aware that they're on an anticoagulant. It's real easy to bleed. If they bang their head and get a headache, straight to the ER. If they feel anything involving bleeding, if they cough up coffee grounds, if their stools are black and tarry, if their urine is pink, anything indicating any bleeding anywhere, straight to the ER. Don't pass go, do not collect $200. It's no monopoly thing. No. Here's a couple complications that can happen. As with any surgery, there's always a possibility of complications. Arterial dissection, where they get the catheter in there and they accidentally perforate the artery. Well, then they'll have to go into surgery and get that sealed off. Haven't seen that yet. Cardiac tamponade. Your heart operates in a sac, pericardial sac. Your heart beats and there's this little sac around it. Inside that sac is fluid that's called the pericardial sac. If we should happen to perforate the heart anyway, fluid can leak into that pericardial sac. And what happens is the fluid in the pericardial sac puts pressure on the heart and the heart can't beat as efficiently. Usually if somebody has pericardial tamponade, you listen to their chest and their heart rhythm, their heartbeat sounds very muffled and they'll experience a lot of chest pain. Now, normally this can be handled at the bedside. Basically, the doctor takes a needle, puts it underneath their sternum, goes in and aspirates the fluid out of the pericardial sac and it'll be better. Usually does not require surgical intervention. Other problems, hematoma at the site. Basically a hematoma is just bleeding under the skin. So you get this big bruise where the catheter went in. We usually just monitor those. There's really not much else you can do. You can apply ice packs and things like that to help it. And bleeding at the insertion site. That's what I was talking about, where the clot just doesn't quite take and they end up bleeding wherever they had the catheter in. So these are the things we kind of already talked about. Any questions on catheterization? Anybody out there ever had a catheterization? No. Okay. You're all too young. I haven't either. Moving on. The other surgical procedure we're going to talk about is coronary artery bypass graft, or we also call it a bypass, or CABG, CABG. Where did my thing go? There it is. And sometimes you'll see it CABG times 3 or CABG times 4 or whatever. That's the number of vessels they bypassed. So in other words, if you're right descending artery and your left descending diagonal and your circ, all 3 of those are occluded, then they will bypass all 3 and you've had a CABG times 3. So if you see that in the charting, that's what it's saying. This is an invasive procedure. They cut your chest, they go in, they separate your ribs from your sternum on one side, and they open up your chest and they get in there. And what they're doing is they're redoing your plumbing, and they're taking arteries, they're bypassing. This is much easier to explain with the picture. But basically, it's artery bypass graft, because we're taking an artery from somewhere else in the body and we're grafting it onto the heart. Here is a good example right here. If somebody in this area of the heart, there's a vessel, say you get into the cath lab and this vessel's occluded and this vessel's occluded and this vessel's occluded and this vessel's occluded. It's like, no, we're not going to mess with that. They will go in and take a vein out of your leg. This is a saphenous area vein, and they will plug it into the aorta of the heart and plug it in to, well, I'm sorry, the occlusion would have to be at this end over here. They will plug it in downstream from the occlusion. This is where the occlusion would be. And they plug it in down here. And now this area of the heart is now getting blood again. Now there's also an artery up that goes to the mammary area of the chest. And if it's on this side of the heart, and say you have a massive occlusion right here, they could just disconnect that artery from the mammary area of your chest, reroute it, and plug it into the heart. So that one's already coming out of this part of the aorta. Not aorta, but this goes off to the vein off of the aorta. I can't remember what the name of it is. But anyway, they graft this in here, and now everything down here is getting blood again. And like I said, I've seen bypasses times 5, bypasses times 6. I mean, in that case, somebody's heart is just really a mess. But the only other option is a heart transplant, which is almost impossible to get. So this is a good substitute. And people can have a CABG and live another 40, 50 years, you know. I mean, once you get blood flowing. Now here's an example of the saphenous vein. This is the saphenous vein out of your calf. And usually in a CABG operation, you'll have 2 doctors, or you'll have a doctor and a PA or a nurse prac. And while the PA or the other doctor is down here pulling the vein out of the calf, the other doctor is up here working on the heart. So he pulls the vein out, hands it to the doctor, he puts it in there and he splices it in. But this is an example of the saphenous vein being placed in the heart. When is those done? Usually, if there's more than 50% an occlusion of the left ascending, what does LAD stand for again? Oh man, my brain is not working today. Anyway, this is the main left artery of the heart. More than 50% of occlusion, or more than 2 vessels are occluded. They may go ahead and refer them out of the cath lab and over to get a CABG. It's up to the doctor. Once they take a look at it, they go, nope, I can't angioplasty that particular vessel. They're going to have to go to surgery. Nursing considerations for open heart surgery, and you can bet there's a lot of them. I mean, we literally have cracked this person's chest open and exposed the heart And we've also cut a big incision in their leg. And don't be surprised when the open heart patients complain more about the leg than they do about the chest. There's a lot of nerves down in the leg. The further out from the part of the body you get, the more nerves there are. Because we have nerves at the end of our fingers and toes, because that's what we use to feel and touch things. So we have a lot of nerve endings more distal from the center body. So, you get into the legs and arms and things hurt worse. So you may have the patient complaining more about leg pain than chest pain. Consent forms, but it might be an emergency procedure. Like I said, guy went down, they did CPR, they defibrillated him, they got a rhythm back, they bring him into the hospital, they race him, straight into the cath lab, and they say, nope, go to surgery, just run straight over to surgery. And there again, the same as with the catheterization, educate the patient on what's going to be happening. Height, weight, vital signs. There again, they may be using contrast dye, so shellfish or iodine allergies. I mean, that will probably happen in the cath lab, and in the cath lab, they'll look at it and go, oh, okay, no, we're not going to do this guy. And then they take him over to open heart surgery. And kidney functions and warfarin and beta blockers, like we talked about. This is all the same stuff as we talked about for catheterization. Now, catheterization can be a procedure where we open up the vessels, but cardiac catheterization or angioplasty or the cath lab can also be used as a diagnostic tool. And in the case of open heart surgery, that's what you're doing, is you're going in and you're looking at the heart using the catheterization, and that shows where the occlusions are. Pre-procedure. Now, in this case, the patient will be totally anesthetized. They will be knocked out completely, usually with Diprovan, Propanol, and then they will be unconscious, and an endotracheal tube will be put down their throat. Now, if anybody out there is a paramedic, or if you've ever been to ACLS training, you will learn all about the endotracheal tube, because you will actually be practicing doing this in your ACLS training. Patient will be under the care of an anesthesiologist for the entire procedure. And an incision is made in the center of the chest and may be made in the leg, depending on what area of the heart they have to bypass. Pre-procedure, discontinue medications like aspirin, warfarin, diuretics. Now, somebody may have gone into the cath lab and had a diagnostic test, or they were going to get catheterization, and they got catheterized, and they were going to have angioplasty done, but the doctor said, no, you need open heart surgery. And if the person is good enough condition, they might just send them home and say, we'll schedule one for you, 2 days from now or whatever. So you may have somebody actually walking in to go get an open heart surgery, in which case is good, because then they have time to discontinue aspirin, discontinue the warfarin, discontinue diuretics. Inform the patient that they are going to be getting an endotracheal tube. They're going to be getting an incision in their chest. They're going to get a leg incision. They may have a chest tube inserted in the side of their rib. They may have they will have a urinary catheter. They'll have IVs, they'll have electrodes there. And this is another thing I wanted to point out. They put pacemaker wires in the heart during the surgery. And they leave those in there so that after surgery, if something goes bad with the heart, they can hook the heart up to a pacemaker. Now, after a couple of days, what they will do is they will just take these pacemaker wires and they will literally just pull them out. But they're in there just as a precaution in case the heart should go into some type of weird rhythm or stop completely. They can put them on a pacemaker. But there'll be wires coming out of the person's chest. They may be out, one of those wires. They said, those are in case we need to hook you up to a pacemaker. And they're only there for a few days, and then we pull them out. But the person's going to wake up with all this stuff attached to them. And they're going to go, what the heck? I was like abducted by aliens. So you might want to explain some of those, what they're doing.
have a question in regards to the pacemaker wires.
Yes,
Is that for every patient that goes in for CABG, or is that case by case?
I've never seen a CABG patient come out without the pacemaker wires.
Okay. Is that something that needs to be placed on the consent?
No, that's a part of the procedure.
Okay.
But while the doctor is in there and he's doing the actual bypass, he'll just put 2 wires in there next to the heart that can be used for pacemaking. And a couple of days later, they just come in and they just pull them out, and they're fine. Did that answer your question?
Yes, it did. Thank you.
Oh, okay. Post-procedure, this is going to be in the ICU. Some of you may or may not move on to ICU, but there again, the precautions we had and, the vital signs, monitor the patient closely because they were under anesthesia. People who've been under anesthesia, they can just stop breathing. So they might come out with a mask on, then you progress from a mask to nasal cannula, from nasal cannula to room air. But you always want to make sure that patient keeps breathing, because the medications we give them and the paralytics that we give them suppress their own body's natural breathing mechanism. So you want to keep a close eye on the oxygenation of your patient after an operation or anesthesia. Encourage the patient to splint. They'll give them a pillow. They'll have, a lot of them have like little heart-sized pillows or whatever. But any of you who've ever bruised a rib or broken a rib, you know what it feels like when you cough. You feel like someone has taken a spear and stabbing it in your side. The same is true of the chest incision. If they have to cough or sneeze or anything like that, and they should cough because they got to keep their airway clear. You got to take that pillow and hold it hard against their chest when they cough, and it'll reduce the pain significantly. Keep a close eye on the chest tube. Chest tube is just to make sure that no fluid builds up in that lung chest cavity area. Manage the pain control. Monitor for infection. Keep a close eye on the chest incision and on the leg incision. And get the patient up and moving as soon as possible. It used to be we'd do open heart surgery. A person would lay in the bed for a week or two. Oh, they've got to heal. Not anymore. They're up the next day. Even though we crack their chest wide open, we don't want them to stay in the bed, because then you increase the chance of skin breakdown, infection, and mostly pneumonia. You highly increase the chances of them getting atelectasis in their lungs and developing pneumonia. So we get the patient up and out of bed as quick as we possibly can. And you will see that in the cardiac ICU, they have this big rolling standing walker that the patient grabs onto, and they start walking them around the unit the next day after heart surgery. It's amazing. It really is. Along that same lines, if they have an incentive spirometer, it's that little plastic thing with the little floating thing in the middle. I should have put a picture in here. And a little tube that you go, and the little thing goes up, a little plastic knob goes up. It's called an incentive spirometer. And usually the respiratory therapist will come in, give them one, train them on how to use it. But quite often that incentive spirometer ends up on the shelf over here somewhere and is never used again. You walk in and you see that incentive spirometer sitting over here, put it on the bedside table and tell them you have to use it, because that keeps the lungs open and it keeps the patient from getting pneumonia. Many people have died after surgery from pneumonia, so we don't want that to happen to our patients. Education. Here we go. I know I had it here somewhere. Encourage the patient to take deep breaths and to use their incentive spirometer as directed by the respiratory therapist. They may have them do it, 4 times an hour or 6 times an hour, whatever the instructions are. Make sure they're sticking to it. I used to tell them, if you're watching TV, there's a commercial, grab your incentive spirometer and start doing a couple deep breaths with the incentive spirometer. Then you can put it back down when the commercial's over. Monitor the incision sites for infection. You may need to instruct them in the use of nitroglycerin if the doctor is sending them home on that. And nitroglycerin, I think I talked about it in a previous class. It's a little tiny little tablet. You put it under your tongue, and if you experience any chest pain, you put it under your tongue. If the chest pain doesn't go away, you take a second. Chest pain doesn't go away, you take a third. If by the third one, the chest pain's not gone, you go to the ER. Healthy diet. Dr. Dean Ornish, I just saw an interview with him last night. A healthy cardiac diet. Usually that involves plant-based diet. Stay away from processed foods, stay away from red meats, maybe stay away from meat altogether. But a good, healthy, plant-based diet with fruit and vegetables is what will keep. It's the only diet known to actually reverse heart disease. And last but not least, exercise. Once they're up and going and running, they need to do some form of exercise because that will keep their heart healthy as well. These healthy diet and exercise, we all know that, right? We're on top of that. Possible complications, pulmonary complications. This is what I was talking about. Does everybody know what atelectasis is? Anybody not know what atelectasis is? Where your lungs just kind of collapse together at the bottom. If someone has atelectasis, they're going to take a deep breath and you're listening to the base of their lungs. You'll hear crack, 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 crack. Oh, you hear cracking on the base of their lungs. That's a bad sign. They need to grab that incentive and they need to start doing some breathing because the atelectasis will lead to pneumonia. And a lot of people have died from pneumonia in the hospital post-surgically. Electrolyte disturbances, keep an eye on their potassium and magnesium. For some reason, after open heart surgery, it adversely affects the potassium and magnesium levels in the blood. Now, potassium, I can understand because it's part of the cardiac pump. I'm not so sure why magnesium, but either of these levels get out of whack, you can get dysrhythmia. So if you get a potassium up around 7, you can actually go into VTAC, which is the same symptom as you get for a heart attack. So keep a close eye on that potassium. And check out for neurological deficits, might be due to low blood pressure, high blood pressure, a blood clot. Okay, I guess I got to fix that, huh? Blood clots, basically it's the stuff you're going to do anyway as a nurse. You're going to keep an eye on their vital signs and their mentation. Any questions on that? I think that's all I got for heart surgery. Yep, that's it. Any questions on CABG or any questions on catheterization? I will stop the share. Okie dokie. In that case, I will stop the recording.